Good evening, everyone.
Very good evening.
Welcome you all to the BNET webinar series. So this is the third webinar from the BNET. So we are doing it on inflammatory myopathy. It's a series of lectures following a case presentation by by the senior neurologist of Bangalore. I welcome you all again, and I thank Inta Celestial for hosting this webinar. First of all, I welcome Dr. Shrikant Swami, who is the chairperson for this evening. Dr. Shrikant Swami is a senior consultant neurologist at RV Hostel Hospital. Welcome you, sir. I welcome Dr. Harram Acharya, very well-known person and very enthusiastic speaker and a very lively, make the talk very lively. He is from Narayana Health. So he is going to speak on EMG myopathy. Welcome you, sir. Hope to see you for a lively evening without any post-session, what do you say, cocktails. And I welcome Dr. Raghunandan Nade. Raghunandan is a professor of neurology at St. John's. He is going to speak on myositis autoantibodies bench to bedside. I welcome Mahendra, dear friend. He is from senior consultant at MS Ramaya Medical College. He is going to speak on the recent advances in the management of inflammatory myopathy.
Thank you, sir.
Welcome Dr. Dhananjay. He is going to present a case. Now, first I request Mr. Arun Chedda, senior manager from Inta Celestial, senior general manager, sales and marketing, Inta Celestial division, to speak about his company and his portfolio. Mr. Arun Chedda, please. Mr. Arun Chedda, you have to unmute.
You have to unmute yourself.
Thank you, sir, and thanks for the kind words. And good evening to all the delegates, ladies and gentlemen. First of all, I am highly grateful to committee of BNET for inviting INTAS to a part of this webinar, and Dr. Uma Shankar, sir, for kind words of introduction also. I, Arun Chedda, Senior General Manager, INTAS Pharmaceutical, Celestial Division. In INTAS, Celestial is dedicated to manufacturing of the plasma product and its uses in the neuromuscular disorders and bleeding disorders. And Celestial plant is a WHO GMP certified plant and is one of the first plasma fractionation unit in India with the fractionation capacity of more than 3 lakhs liter in a year. And in INTAS manufacturing human immunoglobulins by the name of Globusil. And we are the first, those who have introduced Globusil 10%, 100 ml, as well as Globusil 10 grams, 50 ml also. Along with that, human albumin is also there. and low salt human albumin is there. And we are the first, those who are coming up with the subcutaneous immunoglobulins. And we are having the factors, anti-hemophilitic factors, that is a factor 8 and factor 9. And we are coming up with fibrinogen concentrate and prothrombin complex concentrate. And we are in a near future, we will provide you the C1 inhibitor also, as well as IgM enriched immunoglobulins. We at Celestial are committed to provide the quality products for your patients and will continue to do so. As on date, our IVIG brand, that is Globusil, has served more than 30,000 patients under the able hands of prominent clinicians and the neurologists. Now, without wasting much of our time, it's my privilege to introduce the India's most prominent neurologist, the chairperson of today's Dr. Shrikant Swami. Dr. Shrikant Swami done his MD from Gulbarga University, DM, and he is DM from Shri Chitra Institute of Medical Sciences, Trivandrum. And he has served as an associate professor of neurology at MVJ Medical College, Bangalore. He has served as a professor of neurology at Vidhi Medical College, Bangalore, and has worked as a senior consultant at Apollo Fortis Malya Hospital, Bangalore. Dr. Shrikant has conducted many public awareness programs and CME. He is currently the head of neurology at Esther RV Hospital, Bangalore, and he is the member of Indian Academy of Neurology, head and neuromuscular subsets of AN and Indian Epilepsy Association and American Academy of Neurology. His area of interest includes stroke, movement disorders, and headache and facial pains. I am taking much of time. I am handing over this session to Dr. Shrikant Swami. Thank you. Thank you for all the people. Thank you.
Thank you for your kind words. Good evening, everybody, all the speakers and the attendees. It's a pleasure to chair such an important session today. And today's topic is the idiopathic inflammatory myopathies. As we are all aware, this is one of the rare muscle diseases, but identifying these rare muscle diseases is important to in terms of treating them at the right time and treating them properly and diagnosing them properly. And it goes back to 1887 when first inflammatory myopathy, that is polymyositis, was described. Subsequently, after about 10 years, dermatomyositis was described in detail in case series. And of nearly a century, inclusion body myositis described in a series in 1978. So there was a big gap from dermatomyositis description to the inclusion body myositis. Subsequently, now of late, there are 5 groups. Earlier, we used to know 3 groups only: polymyositis, dermatomyositis, and inclusion body myositis. Now, the latest group of this inflammatory myopathies consists of 5 different types: polymyositis and dermatomyositis, inclusion body myositis, immune-mediated necrotizing myopathies, and of course, overlap myositis of late. And there are a lot of developments in this field in terms of diagnosis, identifying autoantibodies to categorize these different myopathies, and of course, a lot of advancement in the treatment modalities. Today, faced with all our eminent speakers, each one is going to speak about each part of this big group of idiopathic inflammatory myopathies. Without wasting my time, I will request Dr. This case. Dr. Gupta,
Yes, I'll start.
you can.
Share this. Is the screen visible, sir?
Yeah, go ahead. Good to go.
Okay. So good evening, everyone. I'll be presenting this case of a 54-year-old man who presented to us with complaints of weakness of all 4 limbs for the last 2 weeks. This started with weakness in the lower limbs, mainly difficulty in getting up from a squatting position, which was followed by difficulty in climbing stairs, followed by weakness of the proximal upper limb, mainly as difficulty in combing his hair. The weakness was associated with pain in both arms and thighs for the last 2 weeks, and he also complained of buckling of the knees for the last 1 week. He had no features suggestive of distal weakness, no sensory complaints, no sphincter disturbances, no complaints suggestive of bulbar weakness, no history of recent fever or infection, and he was non-diabetic, non-hypertensive, and was not on any chronic medication. On examination, the patient was moderately built and nourished. Vitals were stable. He had swelling and induration of both his arms and thighs. However, he did not have any skin rash. Coming to central nervous system examination, higher mental functions and cranial nerves were normal. There was no facial weakness, no bulbar weakness. However, he had a significant neck muscle weakness, mainly neck flexor muscle weakness. Tone in limbs was decreased.
Can the technical support help him?
Yeah. So in proximal upper limbs and lower limbs, the muscle power was 2/5, and in distal upper limbs and lower limbs, the muscle power was 4+/5. Reflexes were decreased. His respiratory muscle strength was normal, and there were no sensory deficits. So in view of a subacute progressive pure motor proximal weakness associated with swelling and pain in both arms and legs without any skin rash, the first possibility we thought of was a muscle disease. It might have been an infectious or an immune-mediated muscle disease. Coming to investigations, his complete blood count showed a leukocytosis with neutrophilic predominance. Other renal function and liver function tests were normal. Total CPK was very high. It was 35,000 international units. Infectious workup was negative. However, ANA was 3+. A needle EMG showed evidence of a myopathic potential. In view of a very high CPK and an ANA of 3+, we sent for a myositis panel antibodies, which showed positivity for MI2 antibodies. So as we will see later in our discussion, that the MI2 antibody positive inflammatory myositis is the dermatomyositis. So we treated this patient initially with steroids. However, because of inadequate response, we had to give rituximab. The further follow-up is awaited as because of the COVID, the patient was unable to come back. Now, one question rises that this patient had no skin rashes, but the antibody positivity was for MI2, which is associated with dermatomyositis. So here we have to remember then that in many of the biopsy-proven cases in large series, almost 6 to 8% of cases have shown no rashes. And this has been termed as adermatopathic dermatomyositis or dermatomyositis sign dermatitis. So even in patients with a subacute progressive pure motor proximal muscle weakness without any skin rashes, we should always consider dermatomyositis as it is one of the most common inflammatory myopathies. Thank you.
You can show me, sir.
It was a little difficult to make out. The case was that even though a patient had no skin lesion, autoantibody detection, the diagnosis. There are different types of dermatomyositis wherein somebody skin lesions have muscle weakness itself. The tendency is to diagnose them based on the autoantibodies, and sometimes MRI of MRI may be very helpful. So there are a lot of developments in this field to diagnose without even the biopsy also. So it's not necessarily that the patient should have a skin lesion in all dermatomyositis. So they can have predominantly muscle weakness itself. So still, if the autoantibodies are present, we can still make a good diagnosis of dermatomyositis, and accordingly it helps us to manage them properly. I think it's an excellent case wherein if we don't realize that skin manifestation may not be prominent, then we may likely to miss the diagnosis. Now I will invite Dr. Hariram Acharya give a talk on EMG findings in the inflammatory myopathies. Dr. Acharya is a neurologist with a special interest, and also has got a interest in neurophysiology, and he has taught about the details of neurophysiology in various diseases. So you are going to hear him give a talk about this electrophysiology, or especially examination idiopathic inflammatory myopathies. Dr. Acharya, please. Dr. Hariram Acharya, can you?
Yeah. I'm coming.
Right.
There is a. Can anybody see this? Everybody see the screen?
Yeah. It's fine, sir.
It's fine. Okay.
The slideshow.
Okay. Yeah. Is it okay now?
Yes.
Yeah.
Yes.
Okay. Now, when I'm playing the videos and all that, I'm going to take my headphone off, because I don't know whether you will be able to hear me very well or not with the with my headphone on. But anyway, so thank you very much for having me, and it's an honor and privilege when our BNET Dada tells me that you have to come and give a talk. I don't question him at all. I just go, yes, sir, when do you want me? And I come there. That's it. So it is an honor and a privilege to be here. And without much, and it's also, I want to thank the INTAS people for organizing this wonderful program, and, let us do the best we can. Now, anyway, so EMG in myopathy, I'm not going to be talking only about inflammatory myopathy in EMG in inflammatory myopathy. How exactly we evaluate the patient with the myopathy with EMG studies. That's the main idea of this talk for about next 20 minutes or 25 minutes or so. Now, why do we need EMG nerve conduction study in myopathic disorder? You know that the patient has myopathy. You said, why do you need nerve conduction study? The reason is because, first of all, we have to confirm that the patient has myopathy and not something else. Because proximal weakness does not mean that the patient has only myopathic problem. It can be a neuropathic problem as well. You have to rule out mimickers such as motor neuron disease, which can present with the muscle weakness, sometimes proximally. Motor neuropathy such as variants of CIDP can present that. And patients with the neuromuscular junction disorders, especially the presynaptic neuromuscular junction disorders, and sometimes the limb girdle type of myasthenia gravis may also present with proximal muscle weakness. So we have to rule out all these possibilities, and EMG nerve conduction study is one of the valuable tools in this. And number three, another reason is sometimes, certain patterns, when we do the EMG study of these patients, certain patterns may help us that, okay, this is probably what we are dealing with here. And we may order the appropriate test to, and sometimes, the genetic testing and all that, which I'll come to all these things in a minute. And it also, the EMG also helps in determining the site for the muscle biopsy. And even though nowadays people depend upon the MRI scan or neuromuscular ultrasound studies, etc., to determine the site of muscle biopsy, EMG was the first thing which was used for several decades actually to determine the site of muscle biopsy. It is still valuable. And also, remember, in patient, for example, in order to determine the progression or response to the treatment. Now, let us say patient is inflammatory myopathy, has been on steroid therapy for 3 months, 4 months or something, and the patient has responded well to treatment, and he starts deteriorating again. Now you question whether this deterioration is the progression of his inflammatory myopathy itself, or is there a steroid myopathy? This is where the EMG can sometimes help. Now, we always do nerve conduction studies first. Even though we are suspecting EMG, we don't jump to only EMG studies. We always do the nerve conduction studies first, because we have to rule out a neuropathic disorder mimicking a myopathic disorder. We do one upper and one lower extremity, motor and sensory conduction studies. You don't have to do all 4 limbs EMG nerve conduction studies for these patients. One upper and lower limbs, preferably one motor and one sensory conduction study with the F waves are necessary. And when you are doing the motor conduction study, if this compound muscle action potential amplitude in the motor study appears low, you must always exercise the patient for 10 seconds to see whether there is an incremental pattern in the compound muscle action potential. And I have had patients where the presynaptic neuromuscular junction disorder, such as Lambert-Eaton myasthenic syndrome, has been misinterpreted as motor axonal variant of GBS and all that, only to find out that after 10 seconds of supramaximal exercise, compound muscle action potential amplitude increases 300-400 fold, thereby confirming that it is a presynaptic neuromuscular junction disorder. And in addition to these nerve conduction studies, sometimes we may have to do repetitive neurostimulation also to rule out the possibility of a neuromuscular junction disorder. Now, okay, now myopathic mimickers, as I mentioned briefly, we have to rule out motor neuron disease, neuromuscular junction disorder, motor neuropathy such as motor variant of CIDP, and multifocal motor neuropathy, etc. They may all present with the motor weakness, but generally there are certain clinical characteristics which may help us to rule these out. But despite that, sometimes it is very difficult clinically to rule out one from the other. That is why EMG nerve conduction study helps in ruling out these myopathic mimickers. And limitations also, when you are doing the EMG, let us just remember that EMG has its limitations too. And it all depends upon the completeness of your study. If you study only a limited number of muscles explored may determine whether the patient really has a myopathy or not. And the timing of the study also. Luckily for this patient, within 2 weeks of the onset, they did the EMG study and nerve conduction study that showed myopathic pattern. But sometimes, in the acute stage, the EMG may not show significant changes or borderline changes, and you are not sure, in which case sometimes it may be necessary to repeat the EMG study after about 4 weeks or 6 weeks or so. Patient cooperation also decides the amount of, sometimes the patient is very apprehensive when you are putting the needle in and the patient is not cooperative. The spontaneous activity in the muscles may be missed, and a myopathic pattern you want to see may not be seen very well. And experience of the electromyographer, more gray hair you have, you will be able to interpret the EMG a lot better. And it is just an experience, because quite a lot of the findings you are going to see sometimes are subjective. Qualitative assessment of EMG is practiced more rather than the quantitative EMG, which is time consuming. And sometimes also remember that the patients with myopathy may have patchy disease, and some of the muscles that you tested may not show myopathic pattern. And last but not the least, the patient has received treatment prior to coming to see you, and this treatment, whatever the patient, immunosuppressive therapy, for example, in an inflammatory myopathy, may influence your EMG findings. So there is a problem. There are limitations associated with the EMG. Now, EMG, what exactly are the kind of abnormalities we are looking for in the EMG? Basically, there are 3 things we look for. Number 1 is fibrillation potentials, positive sharp waves, and myotonic discharges, which are spontaneous activity, which is the muscle at rest. You are going to be putting the needle in, patient is completely relaxed, and you are looking for the spontaneous activity. And you are also looking for, in response to graded gradual muscle contraction, you are looking for a short amplitude, small amplitude, short duration polyphasic motor unit, which is considered as classic myopathic motor unit potential. And this is often associated with early or very often associated with early recruitment pattern. So brief duration, small amplitude, polyphasic motor unit potential with early recruitment pattern is very highly suggestive. And we are also going to be looking for spontaneous activity, as I mentioned. Now, spontaneous activity, fibrillation potentials and positive sharp waves, both of them have the same significance. They are called denervation potential. Even though they are called denervation potential, they are referred to as denervation potential even in myopathic disorders, even though primary problem is not in the nerve. The reason for that is quite often some of these inflammatory myopathies and muscular dystrophies, etc., the terminal twigs of the axons, which are supplying the motor end plate, they may get destroyed. So basically, it is producing a secondary denervation. And also, sometimes, because of the segmental inflammation and necrosis of the muscle fiber, the muscle fiber action potential may not spread despite coming from the motor end plate. It may not spread to the muscle, thereby producing the similar picture to denervation. That's why it is referred to, fibrillation potentials and positive waves are referred to as denervation potential. You will see that. So if I mention in my EMG report that the patient has plenty of denervation potential, that doesn't mean that I'm dealing with the neuropathic problem here. The complex repetitive discharges you may see sometimes, they are not very helpful, except probably to say that the patient has been having this problem for quite some time. Myotonic discharge, this is another spontaneous activity we look for. It is very helpful. Now Now I'm going to show you the. If I keep the headphone on, you may not be able to hear the video very well. And I hope audience will be able to hear this. You know, these are the kind of spontaneous activities we are looking for. These are fibrillation potentials, which have got a very sharp sound. When you put the needle, patient is completely relaxed, and you don't have to do anything at all. Just to put the needle in. As you are putting the needle in, advancing the needle into the muscle, you are going to see these fibrillation potentials. You may also see positive sharp waves like this. Sorry, I go back a little. I apologize. There you go. Positive sharp waves. Yeah, these are, you know, same significance as fibrillation potentials. Everybody knows about them. They have got a positive wave followed by a long negative phase. And this is characteristic appearance of positive sharp wave. This is what we will be looking for. And we are also looking for, sometimes the patients can have a combination of both fibrillation potentials and positive sharp waves. Either of these are significant. Whether you see fibrillation potentials or positive sharp waves, they have the same significance, okay? This is a combination of fibrillation potentials with a positive sharp wave. Now, you have to be careful that interpreting this as fibrillation potentials with positive sharp wave to make sure that the patient is completely relaxed. Otherwise, you may interpret this as a myopathic potentials and all that, but this can be easily mistaken. But the most important thing to remember is patient is completely relaxed. If you find this spontaneous activity, that means there are plenty of fibrillation potentials and positive sharp waves. Now, this is the perfect example of a complex repetitive discharge, which is a typical jackhammer sound, perfectly regular EMG sound. Even if you are 1 mile away from the EMG machine, if you hear this sound, you can say that this is a CRD. Sometimes it is fast like this, sometimes it is slow, but it is perfectly regular sound. And quite often, you will see this kind of myotonic discharges, which have a characteristic waxing and waning pattern with typical so-called dive bomber sound. It doesn't sound like a dive bomber sound, apparently, according to some war veterans I have spoken to. And they said dive bomber doesn't sound anything like this. But to me, it sounds like my grandfather farting. So anyway, so this is a typical myotonic discharge you should be looking for. So spontaneous activities, this is what you will be seeing. Now you are going to be asking the patient to make a very small muscle contraction. What you are going to be seeing is even with that muscle contraction, you are going to see brief duration or small duration, short amplitude polyphasic motor unit potential. This is one of the characteristic findings, even though it is not specific for myopathy. Let me just emphasize that. Short duration and low amplitude is because muscle fiber drop out, either it is inflammatory myopathy or whatever it is. If the muscle fibers are getting destroyed, motor units will have a less number of muscle fibers, and you are going to have a shorter duration motor unit potential. And polyphasia is because of the asynchronous firing of the dysfunctional muscle fiber. This is what happens if you, on the left-hand side of the screen, you can see there are 10, this is just a diagrammatic representation. You can see the 10 muscle fibers being innervated by one motor axon. And at the bottom of that, on the left-hand picture, you can see the normal motor unit with nice amplitude, nice duration, and triphasic potential. On the left-hand side, on the right-hand side, you see only 5 muscle fibers. The number of muscle fibers is decreased, whatever the reason, whether it is a myopathy, inflammatory myopathy, muscular dystrophy, or whatever it is. If there is less number of muscle fibers, you are going to get a very short motor unit potential, which is polyphasic, as you can see at the bottom of the picture on the right-hand side. Now, this is how the polyphasic, short duration polyphasic motor units look like. They are very short, very clicky sound they have, and very crisp sound. And you can see on the right-hand side of the screen that they are all, in response to very small contraction of the muscle, very small contraction of the muscle, you will see multiple polyphasic short duration motor unit potential. And recruitment pattern, I will just skip this. This is a motor unit recruitment, what you are studying in a neuropathic patient, for example. You ask the patient to contract the muscle, and you are going to see only 1 or 2 motor units, especially when it is severe. Whereas in patients with myopathic disorder, this is what you are going to see. For the same degree of contraction, multiple motor units are coming, and they are filling the screen, and it's so easy to identify these. This is the characteristic early recruitment pattern you see in a myopathic disorder. Okay, so brief duration, small amplitude motor unit potential. Let me just emphasize here, Brief duration, small amplitude polyphasic motor unit potential are not specific for myopathy. Sometimes it can occur in neuromuscular junction disorders. Sometimes from early reinnervation in patients with severe neuropathic disorder when the reinnervation is taking place. And mixture of sometimes, to confuse the issue further, you can have short and long duration polyphasic motor unit potential, combination of both neuropathic and myopathic motor units in the same patient, same muscle. This can happen in inflammatory myopathy. This can confuse the picture. Now, what are the patterns we are looking for? These are the 4 or 5 patterns we are looking for. One is myopathic motor unit potentials with fibrillation potentials and positive sharp waves. Now, this is the most common type we are going to see. Second pattern you are going to see is just myopathic pattern without fibrillation potentials and positive sharp wave. These are all significant. That's the reason I'm sort of briefly touching upon them. Sometimes the patient can have prominent myotonic discharges. Whichever needle muscle you put the needle in, and the patient either in response to the needle insertion or in response to percussion, you may be able to find these myotonic discharges very easily. Complex repetitive discharges sometimes you see in certain myopathic disorders. They're not really that helpful. Also remember, the last pattern is sometimes the patient can have myopathy with the normal EMG. This does not rule out myopathy. Myopathy with prominent fibrillation potentials. What are the most important conditions which are associated with prominent fibrillation potentials and positive sharp waves with the polyphasic, short duration, small amplitude, myopathic potentials with early recruitment? That is what I'm talking about, myopathic pattern with the fibrillation potentials and positive waves. These are the important categories. One is inflammatory myopathy of whatever type. Muscular dystrophies can do that, and toxic myopathies. These are the most important things you consider when you have fibrillation potentials and positive sharp waves associated with myopathic potential. Congenital myopathies, metabolic myopathies, infections, etc. are less common causes. Now, second pattern is myopathy, just myopathic pattern only. You find short duration, small amplitude polyphasic potential, but you don't find much of fibrillation potentials or positive sharp waves at all. This is called so-called bland myopathy or non-necrotizing myopathy. This kind of bland myopathy or myopathic pattern only can happen, generally indicate that congenital, metabolic, or endocrine myopathies are the most common reasons for this kind of bland myopathy. So EMG patterns can help you to determine what is likely to be the underlying problem sometimes. It is not always 100% reliable, but it helps. And myopathy with myotonic discharges, of course, everybody knows about myotonic dystrophies causing these myotonic discharges. So always remember, myotonic dystrophies associated with myotonic discharges always are associated with myopathic potentials and very often with fibrillation potentials and positive sharp waves. Whereas in patients with myotonia congenita, paramyotonia, and hyperkalemically periodic paralysis, you can only find myotonic discharges without myopathic motor units, without fibrillation potentials or positive waves. So it helps in some patients to distinguish between the two. Also, I have put there that chronic inflammatory myopathies can also show myotonic discharges. So just because you find myotonic discharge, don't jump to the conclusion that, okay, this is myotonic dystrophy, this is not inflammatory myopathy. Especially in chronic inflammatory myopathies, you can find myotonic discharges, okay? Myopathies with the normal EMG. This is what I said. Sometimes you may not find any myopathic potential, no fibrillation potential or positive sharp wave. You must consider these possibilities: steroid myopathy, storage myopathies, or quite often congenital. Most of the congenital myopathies may have only a few myopathic potentials, which you may miss. Most of the other muscles may show completely normal EMG. So this does not rule, normal EMG does not rule out any kind of myopathy. You have to be aware of that. You need to be also aware of certain facts about EMG and myopathy. No single EMG finding is pathognomonic. Just because you find some EMG changes don't jump to the conclusion, yeah, this is typical inflammatory myopathy or something like that. But there is nothing typical about the EMG finding. Certain EMG patterns I may help you in determining what kind of investigation you do. Also remember that the concordance of EMG with the muscle biopsy is 70 to 90%. Even in the best of hands, muscle biopsy may show evidence of inflammatory myopathy or muscular dystrophy, and the EMG may not throw much light on it. This kind of discordance can happen in about 20 to 30% of the patients. So don't feel bad about it, that, oh my God, I am not a good EMGer or something like that. It has nothing to do with you. And EMG is very useful for selecting the muscle biopsy site as well. And in inflammatory myopathy, certain facts I need to mention here is always test the paraspinal muscles because they are the most sensitive muscles for detecting the myonecrotic fibrillation potential, positive sharp waves, etc. And they have about 90 to 95% yield. Even if the proximal muscles don't show it sometimes or show only a very borderline changes, paraspinal muscles, especially the lower thoracic paraspinal muscles, might help. And when you are doing the EMG in a patient suspected to inclusion body myositis, always do these three muscles: flexor digitorum profundus, quadriceps muscles, and tibialis anterior. It's not just about two proximal muscles, two distal muscles, because those muscles are likely to show very high likelihood of sensitivity is very high to detecting the myonecrotic changes in this muscle. And fibrillation potentials and positive sharp waves do not occur in all patients with polymyositis and dermatomyositis. They may present only in 50 to 75% of the cases. Other patients may not have this. You may have only myopathic pattern, especially if the patient has been on steroids or any immunosuppressive treatment. You may not find any fibrillation potentials and positive sharp waves. And steroid myopathy, as I mentioned to you, may not show any fibrillation potentials and positive sharp wave. And in chronic myositis, sometimes to confuse the issue, you may have both neuropathic and myopathic motor unit potential. And quite often, the recruitment pattern of the motor units helps you, because most of these patients have early recruitment or almost a normal recruitment. If we have a large amplitude, long duration motor unit potential, plenty of them, and the recruitment pattern is normal or increased, it is actually myopathy. And having said all this, let me also conclude this, that by saying that what is the future for EMG in myopathy? EMG is always, remember, EMG is an invasive procedure, and it is not very comfortable for the patient because you are poking the needle in different parts of the body, and showing the needle itself, sometimes patients can have neurocardiogenic syncope. And also I mentioned about the limitations of the EMG because it's not always positive when you really expect to find fluoride changes. The reason why this is going to be a future is in myopathic patients, the MRI scan of the muscle is becoming more and more popular, and so is the neuromuscular ultrasound, muscle ultrasound. Probably these modalities of the investigations may replace EMG in the future, in about 5 years or 10 years or something like that. It is very likely people like me can become redundant, unfortunately, and neuroradiologists are going to have a field day. Now, as you can see here, I'm not going to the details of MRI because that is not the idea of this talk. You can see at the top there is a normal T1 weighted image of the thigh muscles, looks completely normal there. In the bottom tracing, I put two arrows there. Anterior thigh compartment muscles are all showing hyperintensity signal, thereby showing that that is a myopathy. Okay. Similarly, MRI, in inclusion body myositis, dermatomyositis, necrotizing myopathies, etc. The one at the top panel there is all normal MRI scan, and the bottom three panels are all showing abnormal MRI scan, which is very, very highly sensitive and specific for determining the pathology in the muscle. And to add to insult to injury for we electromyographer, they have come out recently with the PET scan of the whole body and PET MRI scan as well. And this MRI scan on the right hand side, PET MRI scan, the red man, pink man standing there on the left hand side, all the muscles are showing hypermetabolism, thereby showing the diffuse nature of the myopathy. Now, this PET MRI scan has got a lot of value, compared to EMG and all that, not only in determining the extent of myopathy, and PET MRIs can also tell you whether any other system is involved in addition to the muscle. That's the advantage, especially in patients with overlap syndrome or patients who have interstitial disease, lung disease, cardiac problems, etc. PET MRIs can show you additional changes, which of course you can't do. And number three, with the EMG. Number three, it can also show you, as you can see in the last diagram here, on the left hand side, you can see the picture at the bottom there, MRI, PET MRI showing increased metabolic activity in the thigh muscle. On the right hand panel, you can see the axial section taken during the whole body MRI scan, axial section with an arrow pointing at a small nodule in the left breast of the patient. This is the PET MRI scan, not only show whether there is a myopathy or not, it can also tell you whether other organ systems are involved or not. Number three, quite a lot of inflammatory myopathy patients are screened for malignancy, as I'm sure my other speakers are going to be talking about it. PET MRI can even find out as small as 7 millimeter size tumor nodules in the PET MRI scan. thereby showing the associated carcinoma-associated inflammatory myopathy. So carry home message, EMG is currently, it has a role in the evaluation of myopathy, no doubt about it. But also remember that limitations of the EMG. EMG is not a single finding is pathognomonic, but certain patterns may help you in narrowing down the differential diagnosis, and concordance between the EMG and muscle biopsy is 70 to 90%. It is never 100%. So don't feel bad if you don't find the findings you are looking for in the expected finding in the patient. And in patients with suspected inflammatory myopathy, always do the paraspinal EMG because they have the highest yield of almost 90 to 95% sensitivity. Normal EMG does not rule out inflammatory myopathy. Let me point that out. It doesn't rule out inflammatory myopathy. And EMG may have, in about 10 years' time or so, when the MRI, PET scan, neuromuscular ultrasound become popular techniques for evaluation of the myopathy, I think we EMGers may lose relevance in the future. Thank you. That's all I have to say. Sorry, I have exceeded the time limit. I apologize.
Thank you, Dr. Hariram, for an excellent review on electrophysiology in myopathies as a whole, because it's a vast topic, but you covered so nicely, including the most basic things for many of the junior consultants and the residents. It will be very useful. We heard from Dr. Acharya that electrophysiology is not the diagnostic tool to diagnose, but it helps us to diagnose. As we always say, electrophysiology is an extension of detailed clinical examination in diagnosing a particular problem. So if we get the expected findings, well and good, it may help us. But if you don't get, still we may have to make the diagnosis based on the other investigations and clinical features. So now I think we will open this topic for discussion. Dr. Hariram will take the questions if there are any questions for him.
Raghu, can you not share the slides?
Okay.
If there are any questions, please type the question.
I have a question for Dr. Hariram.
Yeah.
What are the minimum amount of muscles you want to test, in a situation when there is an indication for myopathy, inflammatory myopathy?
Generally, generally, the principle is you test two proximal muscles. For example, trapezius, deltoid, and biceps are the beautiful muscles to study in the upper extremity. Similarly, in the lower extremities, vastus lateralis, vastus medialis, iliopsoas, and gluteus maximus. These proximal muscles, two of the proximal muscles. Distal muscles, you can take FDI, for example, in the upper extremity. You can use flexor digitorum profundus muscle in the forearm. And in the lower extremities, distal muscles, you can use tibialis anterior, for example, and gastrocnemius, distal muscles like that. Two proximal and two distal muscles. In a patient who has got diffuse pathology, this is all that you need. But sometimes if you don't find the EMG findings that you are looking for, that is when you need to be a little careful before saying that, oh, no, there is no myopathy here or something like that. Be a little bit more extensive. Of course, you have to depend upon the patient cooperation. If the patient is screaming and shouting, you can't keep poking the needle everywhere for the patient. You have to be careful.
But you would do for all four limbs, or you would do for, two
if
limbs or three limbs?
If I get the answer in one upper and one lower extremity, I don't do all four limbs. But if I don't find the changes I'm looking for, I may do the two proximal and two distal muscles on the opposite side as well.
Right. Thank you.
So, Dr. Hariram, there is one more question: whether appearance of neurogenic potential on EMG in myopathy is related of myopathy?
Say that again. I'm sorry, I didn't get the second part of the question there.
One question from Dr. Akash is that whether the appearance of neurogenic potential on EMG myopathy is related to the duration and severity of myopathy.
Yes, that's what we always thought, but they say that that's not always true. That is not always true because, yes, most of the time you are going to find long duration polyphasic motor unit potential along with the short duration myopathic potentials and all that. You find that in chronic stages, but that's not within just 4 to 6 weeks. Sometimes you may find the long duration motor unit potentials as well. And so don't be surprised by that. And doesn't rule the myopathic disorder at all.
Okay.
What happens to the EMG if there is a combination of neuropathy and myopathy? A lot of
what happens?
study conditions and all can have that.
I know, it can happen, so that's why, you do the recruitment pattern analysis. One thing which actually helps, it's not always 100% reliable. Let me point out that it's not 100% reliable. Recruitment pattern. If you find that, you are finding long duration motor-oriented potential, plenty of them, in addition to some questionable myopathic potentials and all that. If the recruitment pattern is normal or the recruitment pattern is early, that is how it points out towards the myopathy for you, because you don't expect to find a normal or increased recruitment pattern or early recruitment pattern in chronic neuropathies.
Thank you.
And there is one more question from, if you select muscle for biopsy based on the EMG, when is the ideal biopsy to avoid EMG-induced damage in the biopsy?
I know, because that's the reason why we do the EMG on one side and write down in our report that this muscle shows the highest number of myopathic potentials and FIPS and positive waves. So please select this particular muscle for the biopsy on the opposite side. So we leave that muscle for the muscle biopsy. Now they says, if you have done on both sides and you put the needle in all the muscles or something like that, it is better to wait for at least 4 to 6 weeks before you do the muscle biopsy on that side, because that inflammation from the injury to the muscle from your needle can persist for 3 to 4 weeks.
Thank you. I think that answers the questions. There are no more questions. I think we will topic, that is myositis autoantibodies bench to bedside by Dr. Raghunandan Nadig. I think all of the viewers are also aware that Raghunandan Nadig is one of the young and dynamic neurologists in Bangalore, in St. John's. He is a professor of neurology, and he is frequently seen in any academic activity in Bangalore. And his field of interest is in autoimmune diseases and demyelinating diseases. And now he is going to talk about autoantibodies in inflammatory myopathies. Dr. Raghunandan, please.
Thank you, sir. Thank you for your kind introduction. Thank you, Dr. Umashankar, for the initial introduction. So at the outset, thank BNET giving this opportunity. I think as a neurologist, when we were either during MD or this one, we didn't know much about these autoantibodies, and we were not taught well, or we didn't read about it much. So recently we are seeing all these things, a lot of jargons, names, Joe, Re, V, and all is there. I'll try to tell you, or at the end of this talk, I think people should know few basic concepts of it. So in next few minutes, 25 minutes, I'll be discussing on all these topics. So introduction and few questionnaires I will give you. Will not discuss the answers in the beginning, and then we'll come back to it in the last. So as we all know, autoimmune disorders like classical prototype is SLE, ANA, anti-dsDNA is positive. Similarly, they will have a biomarker. So inflammatory myopathies, earlier we all knew it's a autoimmune disorder like polymyositis, dermatomyositis, and IBM. So there were not much of inflammatory markers which are known, but way back 40 years back, the first one was detected was anti-Jo1 somewhere in, then followed by MI2. Me too. But subsequently, there were not much was there. But from past 15 years, past 2 decades, there is a flurry of autoantibodies have come. Based on that, there have been the inflammatory myopathies have been classified. So now no longer now all this we will call it as idiopathic inflammatory myositis. So as we were all, what is the classical features? They usually presents with proximal muscle weakness and disability. This happens due to the inflammation of the muscle. And additionally, you will be looking for the features of skin involvement, look for any other multi-organ involvement, presence of ulceration, calcinosis, and always look for any hidden malignancy. And classically, when we were all taught, inflammatory myopathies are inclusion body myositis, dermatomyositis, and polymyositis based on the histopathological characteristics. Whereas in a dermatomyositic, you see perivascular, perivesicular atrophy, and the inflammation is around the vessel, like a vasculitis, more of this one. In a polymyositis, actually there is a destruction of the muscle in the central, and inclusion body, you see a vacuolar or rimmed vacuoles. This was a classical. Nowadays, as we have advanced, not many times we will be doing a biopsies much. So as sir was mentioning in the beginning introduction, so polymyositis was known way back around 130 years in 1887. And subsequently by 1891, they classified as DM and polymyositis. As you afterwards, nearly it took almost 90 years to recognize another inclusion body myositis. By 1991, then there is another one, new one came, that inflammatory necrotizing myopathy. So this is basically histological features. So say from 91 till so many advances have happened in the characterization, classification. These are all based on the Bonner classification. Now the classification used is a ULR. So there is one entity now called as non-specific or a what we call as overlap. And as the day goes on, now the polymyositis actually is coming down. The pure polymyositis is coming down. I'll be explaining to that later. And these are all the latest so many antibodies and the treatment which have been recognized. So presently, inflammatory myopathies can be classified as dermatomyositis and overlap myositis. So overlap myositis means the histologically they can have either a polymyositis or a dermatomyositis, muscle pathology with certain antibodies, and they grouped as anti-synthetase syndrome. And then you have immune-mediated necrotizing myopathy. That is a one separate entity where this is classically earlier thought of as a polymyositis. And then you have inclusion body myositis, and then comes the polymyositis. So this is the present classification: dermatomyositis, overlap myositis, and necrotizing myopathy. So as I told, in myopathy, so it is an autoimmune disorder, and it is found that in over 60% of the patients with the inflammatory myopathy, autoantibodies are detected. So what are these antibodies? These antibodies are directed against ubiquitously expressed intracellular complex like protein synthesis. So these antibodies are produced, and so in nearly 60% of inflammatory myopathy presently we can find an antibody, but in nearly another 40% you may not find. So before going to the talk further, I would like to ask the people to vote it. So these are the first question. Antibodies associated with dermatomyositis myositis include all of the following except. So can the poll happen? Hello? Is polling started? Hello? Yeah.
It's there, Raghu.
Yeah. So they can poll. So yeah, we'll go to the second question. Can I go to the second question? I think. Yeah. So the most,
yes.
The most common antibody present in with anti-synthetase syndrome. Okay. We'll come back to this. Third question. Sorry, it's not moving. Yeah. This is the third question. In dermatomyositis, cancer risk is increased if they have following antibodies, except. Fourth question. Immune-mediated necrotizing myopathy usually presents with severe weakness and very increased CK levels, which is the antibodies present. And the last question. Dash antibody is positive in dermatomyositis patients with fulminant interstitial lung disease. Okay, so we'll proceed. My slides are not moving on my computer. Can you help me with that?
Sir, just close the poll.
I have closed the poll. Yeah, it's gone now. Thank you. So now coming back to the talk further, so we'll come back to these questions later. So antibodies in inflammatory myopathies can be broadly classified as myositic specific antibodies. Now we'll be talking this as MSA, not the multisystem atrophy what we come across in.
Sorry to disturb. Sorry to interrupt you. Yeah. There's someone typing in the background. Please mute your phones except microphones, except for the speaker, please. A request, because there's a disturbing noise throughout this talk. Thank you.
Yeah. Can I proceed? Yeah. So the important autoantibody. Important autoantibodies are classified as MSA, myospecific specific, and then you have a myositis associated antibodies. We'll come to the difference between these two. So detection of more than one MSA is same individual is extremely rare. So the main thing is it's a specific for that disease and that syndrome. So you don't find that antibodies in a same patient, two antibodies, and MMAs can sometimes coexist like a Rho, La, and all. Will come to that. And MSS are considered as ideal biomarkers for identifying homogeneous subsets of myositis and genetic factors contributing to this disease. So presence of an antibody will prognosticate the patient, will know the pathogenesis, will also know is there any occult malignancy in them and what is their outcome. So the main important thing is it's correlate with specific clinical manifestation. And as I told you, it will help you in homogeneous group. And myositis antibodies aid in predicting additional. So even though the patient has come with one symptom, like a muscle weakness, if some antibodies are present, you can diagnose that these patients are likely to develop lung disease or calcinosis and all that. So now MSAs can be considered as like a gene problem. So they can have a different phenotypes, but if you have an antibodies 1%, then that genotype is decided. So this can be considered as a genes how we diagnose. Like in LGMD, you can have various presentation, you do the gene. Similarly, we can have a varied presentation. If one antibody is positive, we can group them as one disease. So as I was talking, so we knew this Me2 first antibodies, which was known in 1976, subsequently in 80, Jovan came. So this is all described in juvenile myositis as well as in adult. So after that, from 2005, there is a flurry of antibodies that have been detected. So even if you see, this is the two diagrams down, in the juvenile, nearly 55% of the antibodies are detected after 2005, but in an adult, it is about only 20%. But if you look at this, in children, in adolescent and children, in nearly 30% of the patients, we still don't know what are the antibodies in a patient with inflammatory myopathies, but in an adult, it is about 35%. So nearly in 60% we know, 35%, I think down the lane in another decade, we may find more this Jagrans, LA, EJ, KS and all. We'll come to that. So what are these antibodies? These antibodies are diagnostic specificity. They are against RNA. You should remember that nuclear ribonuclear proteins involved in key process of cell biology such as gene transcription, protein synthesis and translocation, and innate antiviral immune response. So these antibodies are produced against these proteins which are responsible for our gene transcription and innate viral immune response. So this is why an immune response which happens to the virus or any other infections can cross-react and you can develop a myositis. And also this innate immune response can dysregulate itself and they can develop malignancy. So what are MMA? Even though they are also similar one, but they can be present 2-3 antibodies in the same patient, and they are not disease specific. They are not disease specific, and they are usually, when they are present, they are called as myositis overlap syndrome. So there is a common one myositis overlap syndrome called PDM-SSC that is called as scleromyositis, primarily myositis systemic sclerosis. Now we'll come to the antibodies. So how these antibodies are detected by 4 of these methods, either the HEPA cells or a ELISA method, immunofluorescence, and also the electrophoresis, which we are not going to speak about it. This is the different types of, this is a HEPA group. Now coming to we'll come back to this diagram. So one is the anti-ARS antibodies. These are all what I'm speaking is a muscle specific. They are against a tRNA synthetase. So I'll come to that. So then you have something called as an anti-MDA5 melanoma differentiation associated protein. They are RNAs. They are present in juvenile DM. Then you have something called as an anti-SAE, small ubiquitin-like modifier activating enzyme. These are all little difficult. You can remember as SAE. And anti-MI2, nucleosome remodeling deactylase complex. So these are all the complexes which are involved in our protein synthesis and transcriptions. So I think the case was presented was anti-Me2. I'll come to that. And this is the new antibodies. Whatever this has been declared, shown here is one is tumor transcription intermediary factor 1 gamma, anti-TIF gamma. This is mostly seen in dermatomyositis, and NXP2, nuclear matrix protein 2, And signal recognition particle, this is another important antibody. This is classically seen in necrotizing myopathy. And then you have the statin-induced anti-HMJ-CR, anti-methyl glutaric CoA reductase in cholesterol synthesis. And then you have this new antibodies has been detected, especially in inclusion body, anti-C1NA, cytosolic 5-nucleotidase 1A. So these are all muscle-specific antibodies. So now you have, these are all muscle associated, like anti-PMSCL, anti-UNRNP, anti-Rho52, anti-Q. So these are all muscle-specific antibodies. So we have heard these diagrams. I think we'll go and I think some topics, I think it will be, you'll be able to retain. So we'll come to this anti-Me2. So anti-Me2, as I told you, it is a nucleosome remodeling histone deactylase complex, and they classically presents with dermatomyositis. They will have cutaneous manifestation as well as they will have muscle. So you can see a heliotrope rash, Gottron papules, you have a shawl sign here and a V sign here. And they are present in 10 to 30% of patients with idiopathic inflammatory myopathy, especially dermatomyopathies. The important thing about it, whatever I've highlighted, they are lung sparing and they have good response to steroids. So in the olden days, we had seen that many patients, all myositis, some respond, some doesn't respond. Now, if you have this patient, you give antibodies is Me2, you can rest assured they are good response. And one more important thing is they are least associated with malignancy, low risk of paranoia. So there is no need to do a PET scan or workup for a malignancy in these patients. And it is considered as a good prognostic marker. This is the important point of Me2 antibodies. Now come to there is a group of antibodies called as anti-ARS antibodies. These are against tRNA synthesis. So if you remember our MBBS days, we have protein synthesis. We will know the 8 essential amino acids. So if you look at this, these are all the tRNAs, histidyl tRNA, tRNL RNA, alanine RNA. So these are all the 8 antibodies. They are all grouped as anti-ARS antibodies. So the classical one, what we know is histidyl, Jo1, tRNL is PL7, PL12, EJ, KS, Ha, and Zo. So I think this Jo was the first patient, John. That is where it was recognized. And subsequently, I couldn't find all these PL7. I think they are also patient's name whom it was first detected. So what is the importance of these? These antibodies to ARS occurs overall in 25 to 35% of IAM patients. So here the histology of the myositis can be polymyositis, also can be dermatomyositis. Okay, but the presence of these antibodies will group them as anti-ARS syndrome, otherwise called as anti-synthetase syndrome. Classically, they will have myositis, arthritis, Raynaud's phenomenon, mechanical hands, and what prognostically important is the presence of an ILD. So this is where the prognosis of the outcome of the patient. If they have severe ALD, the outcome is not good. So this is a classical anti-synthetase syndrome. Anybody having more than 3 of it, and then you call them as anti-synthesis syndrome. And nearly in this anti-synthetase syndrome, one of these antibodies will be found. Out of these antibodies, in that anti-Jo1 is the commonest one in 20 to 30% of the patients. And lung and joints are the major organs involved. Prognosis is strictly related to the pulmonary involvement. So what is this anti-synthetase syndrome? And recent studies have suggested that antibodies to non-Jo1 ARS are associated with early and severe ILD and poor prognosis compared to anti-Jo1. So if you have a dermatomyositis with Jo1 positive, what you can know is they will have ILD, but the prognosis is relatively good compared to the non-other things. And you should know that many of the ILDs, they may have these antibodies without the classical appearance of myositis, or myositis can come later. So as I was mentioning, the hypothesis is that during the tumorogenesis, some suppressor genes will be suppressed and some proteins can be exposed. One of the classical is the TIF1, that is a transfer intermediary factor 1. So the antibodies which are produced against, they act against the skin and the muscle. We'll come to that. This is a classical syndrome, especially in adults. If you find a TIF1 gamma antibodies, you have to search for malignancy. Exclusively seen in 20 to 30% of the adult, and they will have aggressive skin lesions, as you can see in these patients. These are the treated patients. These are from the BMJ case reports. Whereas they have in adults, in children, the malignancies are less, but in adults, the malignancies are very common. Paraneoplastic is largely involved, and usually the solid tumors, adenocarcinoma of the lung, stomach, or the colon will be there, and this is due to the P53 oncogene suppression. So high antibody levels to anti-TIF1 increase the risk of cancer-associated DM. So a negative antibody prompts to exclude concurrent malignancy. Now coming to the another antibody, what I was talking, NXP2, what one should know is they also have skin manifestation more, and they will have calcinosis as compared to the other persons, so other people. 25% of them have juvenile or adult DM, and young onset diabetes, severe cutaneous lesion, and association with cancer has been also observed. So if you have a malignancy, if you find an NXP2 or a TIF gamma, you should always look for malignancy, do a PET scan in these patients. And NXP antibody occurs in more than 50% of otherwise antibody negative patients and are independently associated with cancers. Now coming to the another important muscle specific is anti-MDA5, and this is an antibody which is associated with what you call as amyopathic dermatomyositis, or clinically amyopathic dermatitis, a CADAM or ADM, and they can have some pustular changes in this one, but the most important thing is they will have aggressive ILD. So if you find a patient with MDA5 antibody in a myositis patient, they will have an aggressive ILD, and the prognosis is very bad in them. Now coming to the other group of like anti-SAB antibodies, they are seen in 88% of the adult DM with severe skin disease. They have a good prognosis, and they are against a SUMO1 activating protein. So these are all the muscle-specific antibodies associated with a dermatomyositis or a polymyositis with skin manifestation. Now comes the SRP. Anti-SRP is signal recognition particle. So earlier we used to see there is no dermatomyositis, no polymyositis, but they have a necrotizing myopathy. So in all the necrotizing myopathy, this antibody was found, and there was abundant myofibrotic necrosis and regeneration with scars inflammation. And these patients were poor response to steroids. So you would have seen some patients like they were not at all responding, and they can have this anti-SRP. So if you have a patient with myositis, anti-SRP come, you can definitely prognosticate, and you got to be very aggressive from the beginning. And coming to the anti-HMGA CoR antibodies, all in the patients who are given statins, this receptor gets upregulated and antibodies can be produced. And usually in a person who has got this HLA, DRB1, so you can find these antibodies which acts against this muscle, and it also causes necrosis and with less inflammation. So it is a necrotizing myositis. Inflammatory necrotizing myositis. So if you have a necrotizing myopathy, then there are two antibodies. One is SNP and anti-HMGCR. And I think in future we may find, but as on today, these two. So if you find a necrotizing, you have to suspect these things. Now coming to the inclusion body myositis, earlier we thought it is still that there was a controversy whether it is a degenerative disease or an inflammatory, but now it is found that in sporadic patients, in these autoantibodies to 5-nucleotidase 1A was found. And this had some poor prognostic factor. So in a patient with inclusion body myositis, anti-CNA1 antibodies is associated with an independent risk of mortality. Classically, they will have, you can see here, weakness of the finger flexors and the weakness of the quadriceps muscles. You can see in the muscle MRI what sir was showing earlier. And this is the late stages. Here you can see, since the lumbricals are spared, they can flex the metacarpophalangeal, but they're unable to flex the finger flexors. And you will see a centronuclear-like features. They'll have a rimmed vacuoles. So if you now see anti-C1A antibodies highly suggestive of a myositis, inclusion body myositis. Now coming to the few, I think I'll rush through these slides. MMA antibodies. So they are anti-Rho, SSCA, anti-PMSL, and anti-Q and anti-UNRNP. They are associated. They will have 1 or 2 antibodies can be there. And PDMS, this is the classical syndrome called as scleromyositis. So scleromyositis can have both muscular and extramuscular clinical manifestation. They can also have Raynaud's phenomenon, ILD, just like a person like an anti-synthesis syndrome, but the antibody is seen as anti-PM-SCL. ILD has the same clinical and pathological significance. Other is Q antibodies. Q antibodies is also suggestive like an anti-ARS syndrome. So if you have an anti-ARS syndrome, you can have all those tRNA synthetase group, or you can have this anti-Q antibody or PM-SSCL antibody. And they are also good. Some patients, really, anti-Q antibodies, they they are refractory to steroids. So one should recognize these things. If you find these antibodies, they respond well to other immunomodulation. Another is anti-UNRNAP. This is what is called, earlier we used to call as a mixed connective tissue disorder. And in these patients, if you find these antibodies, even though they have like a SLE-like features, the renal diseases is very rare. And then ROSSA antibodies, apart from the Jogren-like presentation, they can also have a myositis, like anti-synthesis syndrome, severe ILD, myositis. So in a myositis panel, you have to send this whole panel, which I'll be showing the slide later. So all these antibodies will actually help you in grouping a subset of patients, prognosticate them, and manage based on that. So this is what is the prevalence as on today. Jo1 is seen in 50 to 30% of patients with polymyositis or dermatomyositis, anti-synthetase syndrome. And if you see, all are less than that. SRP is about 5% in polymyositis. MI2 is nearly 10. After Jo is the MI2. This is what you call as melanoma differentiating, that is amyopathic dermatomyositis, clinically amyopathic, and TIF and NX1 and all are associated with malignancy. So MSAs also helps in disease, as I think we will be repeating this. So same disease management and in the recognition. So we have about a cohort of about 175 patients. This is our immunologist and has got this data. In our hospitals also, we found anti-synthetase syndrome about in 45 patients, and in that polymyositis, dermatomyositis and all. So antibodies, if you see here, Jo1 was the commonest one, followed by MI2, then anti-URNAP in 41, 50. So they can have, because they have overlap syndrome, you can find 2-3 antibodies in the same patients. Now, this is the report what we get when we send a sample to the NIMHANS, what we are currently sending. If you look here, all these antibodies are mentioned. Row 50, these are all SRP and these are all muscle-specific antibodies. PMSCL, PM100Q are muscle-associated antibodies, and RO52 is muscle-associated antibody. SRP is a muscle-specific. What is not there in this panel, which has been described, is HMG-CoA reductase antibody against that, and also the antibody of NTSC1 for inclusion. But otherwise, this profile gives you, a patient comes with inflammatory myopathy, you send this panel, you get one of these antibodies, then there is no need to do further workup. There is no need of biopsy. I think biopsy is becoming obsolete. Now biopsy is being done when antibodies are negative and the patient is not responding. Then you want to really know what is really happening, one has to do that. So we'll vote the questions now. So coming back to the question. Okay. So can I have the answers of first and now? Can I have the poll now? I think we'll see how much people have understood before the talk and after the talk. Here the answer is, I think it is obvious. So this is sharing the poll. This is the present share or the first slide or what?
First share.
First share. The now the after the talk means the this one.
Okay.
Yeah, see now I think I have made a difference. So 60% had answered, now 84% have answered, and TIF gamma is nobody answered. That's good. We'll go to the second question. The most common present antibody in anti-synthetase syndrome. Yeah, we'll have the poll, please. So 83. What is the first poll?
This is the first poll, sir.
Now? So 83 to 89. Good. Some still there are some this one. Okay, we'll go to the third question. So dermatologic cancer risk is low. So what is the poll? So here the answer is me too. All of you should do that. I've been mentioning that except me too, other antibodies will be associated with malignancy. Next slide. The poll, please. Okay, this is the first poll. There is a equal 33, 29, 29, 10. Okay, we'll come to that. So 33% have told me too. We'll now see how many have told. Can I get the poll now? No. The previous poll, what happened? Okay. After the lecture, okay, still 61% feel it is me too. So me too is not the me too is the correct answer. Okay. Yeah, next one. Yeah, I think this is a obvious question. I don't think we should answer. I think when MCQs are given like this, both of the above will be most of the time right. Okay, poll please. I think we are losing time on this. Hello. Yeah, correct. So we'll go to the last question and then I'll summarize and end the talk. The last question is, which antibodies is associated with fulminant interstitial lung disease? Before and after the this one. Poll before the talk and after the talk. Yeah, we'll have it and I'll summarize it. So 35% had told in the beginning. Now next one. Yeah, so 74. I think I have made some difference. I think people have attentive and they have learned few things. I'm not able to share the slides. The slides. Yeah, okay. So these are the answers. As I told you, yeah. Okay, in summary, I think we can classify as myositic specific antibodies are tRNA synthetase, Me2, SRP, and these are all the novel new antibodies. SAE, MD5, TIF alpha, TIF gamma, and then associated antibodies, anti-Rho, anti-Q. I think if you know these names, it is enough. So amino acid tRNA synthetase is the Jo, Ha, Ri, Ka, whatever it is, PL10, PL12, and PL7. And then this is one, I think you can read this article in Internal Medicine. So this is a group of overall anti-synthetase syndrome. You can see there will be overlap of the lung. You should look for the skin. You should look for calcinosis. You should look for malignancy. Only if you can see IBM is away from everything. It has got a unique thing. We still don't know whether it is inflammatory or degenerative. And then you have a statin, which is a pure, doesn't have skin, any other arthritis or ILD. So this is how you can pictorially you can demonstrate depict various myopathy. So in conclusion, the key points are, as I mentioned earlier, MSS are present in majority of juvenile as an adult IAM. In adults, anti-T1F1 gamma is myositis associated cancer. So if you get these antibodies, please chase for the malignancy. Anti-MDFA is associated with amyopathic dermatomyositis with aggressive ILD. And if you have to look, if any of those synthetase come positive, ILD is the main manifestation, or if any person is treating in respiratory medicine ILD, they have to check because myositis can come. And anti-HMDCR is statin-induced myopathy, and discovery of novel may provide us to future autoimmunity and cancer. I thank Dr. Ramya, our immunologist, and our postgraduate sharing few slides, and thank all my colleagues who are taking care all this in difficult times. And thank you. This is our team in St. John's, where postgraduates and all. We recently had a MCA inspection. That is what it is. Thank you.
Thank you, Dr. Raghunandan. It was an excellent talk on the multiple areas of diagnosis, especially autoantibodies and how they help in diagnosing and help in management. And I think it is very useful for the young neurologists and the residents, especially because it is one of the, I think, stock questions probably in the theory. And practically also it is very useful in diagnosing and categorizing and managing the different inflammatory myopathies. I think we are running out of time now. We will take one or two questions. There are two questions, Dr. Sorry?
Yes, sir.
Doctor, there are two questions for Raghunandan.
Yes, sir.
One, Rajashri Chakravarti has asked how much antibody titer is suggestive of disease.
Sir, it is actually the titles they are not giving because these are all based on the immunofluorescence and all. They give 1 plus, 2 plus, 3 plus and all. So either 2 plus or 3, there is in the panel, if I go back, they will mention 1 plus is not significant. Anything above 1 plus, 2, 3 or 4 plus is significant. So now the concepts are coming, the certain diseases, titers are prognostication. So if your disease is under control, the titers can come out. But as of now, it is an ELISA based what we have. It's only the positive 1 plus to 4 plus.
And the next question is, Dr. Arvind and Prabhu has asked you, can any one of these antibodies also occur in MND, ALS, or paraneoplastic conditions?
See, in general population also, these anti-synthetase antibodies can be found without any disease. So they are especially, but if you have a myositis and antibodies, they are very specific. But in especially myositis associated antibodies can be seen in general population also. But as of today in ALS, they are not found. That is one of the biomarkers are not there. So once we get a biomarker, I think in future we may have it. But in MND ALS, it is not seen. As of,
thank you, Dr. Raghunandan, for those answers. I think that answers the questions. I think we will move on to the next topic of today, that is recent advances in the management of inflammatory myopathies by Dr. Mahendra. Dr. Mahendra is a very dynamic associate professor working at Ramaya Medical College, and he is very keen in this diagnosing the inflammatory myopathies and immune-related disorders. And I think he will update you all with the recent management protocols and management strategies of inflammatory myopathies. Dr. Mahendra, please.
So, can you see the slides?
Yeah, you can speak.
Yeah. Thank you, Chairperson, for your kind introduction. I'd like to thank BNET for giving me this opportunity. My talk is on recent advances in management of inflammatory myopathy. Before starting, we'll have an audience poll question. Only 3 questions are there. So initial response for glucocorticoids in inflammatory myopathy in the form of normalization of creatine kinase requires 2 to 4 weeks, 4 to 6 weeks, 6 to 8 weeks, 1 to 2 weeks. Next question. How should myositis with dysphagia be treated? Is it with oral prednisone, injection solumedrol, IVIG, plasma exchange? Next question. Presence of which muscle autoantibodies predict good response to rituximab? Is it anti-NXP2, anti-Jo1, anti-MDF5, or anti-Jo1 and anti-MI2? Okay. So, as we already know, initially there were only dermatomyositis and polymyositis. Now we have a new classification which says is it a dermatomyositis, antisynthetase syndrome, necrotizing myositis, overlap myositis, and polymyositis. The question of diagnosing polymyositis itself is doubtful. Now, polymyositis is considered as a diagnosis of exclusion.
Lumbar puncture and workup for infective and autoimmune encephalitis.
Defining optimal treatment regimens as.
Go ahead.
Am I audible, sir?
Yes, you are audible.
Defining optimal treatment regimens has been. 1 second. Due to relative disorders, complex clinical phenotypes, and limited number of randomized clinical trials. So here we have a parable of blind man and elephant. As this parable tells us, we are only partially right when we take only partial information. For example, inflammatory myositis is treated by a rheumatologist, neurologist, dermatologist, and pulmonologist. As we neurologists, we see only muscular manifestations. We may not work up for interstitial lung disease. Rheumatologists see only rheumatic manifestations. Pulmonologists see only interstitial lung disease. So it is not a simple or a one department disease. We have to have a multidisciplinary approach for proper management of a patient with inflammatory myopathy. So what are the clinical predictors of outcome? It is delay in initiation of treatment more than 6 months at presentation, severe muscle weakness at presentation, presence of dysphagia, respiratory muscle weakness, interstitial lung disease, underlying malignancy, cardiac involvement. All these features present a worst clinical predictors or worst clinical outcome in a patient with inflammatory myopathy. So how do you treat? As we all know, initial treatment is with glucocorticoids. So what is the regime and how do we taper glucocorticoids? Usually start with prednisone 1 mg per kg, maximum is 80 mg per day. If patient is severely ill, we can give injection salumetrol 1 gram per day for 3 days, and you can maintain prednisone 1 mg per kg for 6 weeks. After 6 weeks, we can taper 10 mg per week up to 40 mg per day. After reaching 40 mg per day for a week, taper again 5 mg per week to 20 mg per day. After reaching 20 mg for a week, then taper by 2.5 mg every week to 10 mg per day. After 10 mg per week, further taper to 5 mg per day, either by reducing 1 mg every week. So main plan is to keep prednisolone as low as possible, at least less than 10 mg per day. So what are the role of glucocorticoid sparing agents? Why do we require that? It is initiated to reduce cumulative dose of prednisolone, thereby diminishing the steroid-induced morbidity. And current first-line treatment is azathioprine or methotrexate. Patient with profound weakness or significant extramuscular complications may require treatment with 2 drugs from the outset. Azathioprine, as we know, it's an add-on drug. In a randomized trial of 16 patients, compared prednisone with azathioprine with prednisolone alone. At 3 months, there was no difference. However, at 3 years, patient treated with azathioprine and prednisolone combination therapy has a better functional outcomes. So how do we start? We start with 50 mg per day, then increase 50 mg every week to 1.5 mg per kg per day, maximum up to 2.5 mg per day. Response may take as long as 4 to 6 weeks. This is very important because unlike prednisolone, azathioprine and methotrexate takes longer time for action. Methotrexate, there are no placebo-controlled prospective study has been done in dermatomyositis and polymyositis using methotrexate. Methotrexate has a convenient once-a-week dosage. Its starting dosage is 10 mg per week, and you can slowly increase by 2.5 mg up to 25 mg per week. You have to add additional folic acid 1 to 3 mg per day to prevent hematological complications of methotrexate. So before starting other models of treatment, I'd like to define what is a recurrent disease or a flare, or what is a resistant or a refractory myositis. Recurrent disease is after achieving disease control with treatment, some patients experience disease recurrences of flares during or after period of medication tapering. Whereas resistant disease, the disease doesn't respond to conventional approach therapy to remission induction, and other therapies must be considered excluding alternative diagnosis. So in a patient with recurrent disease, we have 2 scenarios. Flare occurring at more than 10 mg per day of prednisolone. We have either option A, addition of glucocorticoid sparing agents if patient is neither on azathioprine or methotrexate. Another option B, where treatment of flare as a resistant disease if already patient is on azathioprine or methotrexate. However, with either action, dose of prednisolone has to be increased to 1 mg per kg per day to re-establish the disease control. Scenario 2, flare at 10 mg per day of prednisolone or less. Increase in prednisolone to lowest dose required to re-establish the disease control. minimally, usually we can maintain up to 20 mg per day to get the disease control, and then again increase the azathioprine or methotrexate to a higher dosage. So what is a resistant disease or a refractory myositis? Initial response for glucocorticoids in dermatomyositis and polymyositis may take 4 to 6 weeks for normalization of creatine kinase enzymes and 3 to 4 months to regain muscle strength. Thus, a patient should not be classified as having a resistant or refractory disease without taking these time factors into consideration. When do we call a patient as a refractory or a resistant myositis? Patient do not respond to glucocorticoids plus azathioprine or methotrexate. So glucocorticoids plus either of azathioprine or methotrexate, patient doesn't respond, we called or diagnosed it as a resistant disease. And what are the treatment options for this refractory myositis? IVIG is one of the option. In a double-blind, randomized, placebo-controlled, multicenter phase 3 study called PRODEM study has recently completed recruitment and data are awaited soon. And when to use IVIG, especially in cases where corticosteroids or immunosuppressants contraindicated, such as in infections or neoplasia, IVIG serves as a reasonable option of treatment. Apart from treatment of muscular symptoms, IVIG has also been reported to be effective in refractory interstitial lung disease and esophageal involvement related to polymyositis and dermatomyositis. Usual dosage is 2 gram per kg over 5 days and then 1 gram per kg monthly for 3 months. Coming to second important drug, rituximab. In the largest randomized double-blind placebo-controlled trial so far regarding the efficacy of rituximab in adult and juvenile myositis called RIM trial, which included 195 individuals refractory to glucocorticoids and at least one of the immunosuppressive agents. Majority, 83% of patients showed a clinical improvement and steroid-sparing effect during the treatment. So in a post-hoc analysis of RIM trial, the presence of anti-Jo1 and anti-MI2 antibodies seem to be good predictors of response to rituximab. So what is the mechanism of action of rituximab? Rituximab targets CD20 positive cells, that is B cell precursors, leading in most patients the depletion of B cells in blood within several weeks of administration. It is a promising agent for the treatment of both dermatomyositis and polymyositis. A variety of dosing regimens have been employed in a randomized trial in a small case series or case reports. So what is the dosage? Majority in rheumatic disease, mainly rheumatoid arthritis, the trend with use of rituximab is to give 2 1 gram dose 2 weeks apart. The same dosage we also follow in inflammatory myopathies, that is 2 1 gram doses 2 weeks apart. So what is the role of cyclophosphamide? Cyclophosphamide usually serves as a treatment escalation when standard treatment or standard immunosuppressions and IVIG are not sufficient in severe case of myositis, especially systemic organ involvement, including lung and cardiac disease. Several uncontrolled cohort studies have demonstrated the efficacy of cyclophosphamide in the case of severe myositis and myositis-associated ILD, with majority of patients improving in both muscular strength and pulmonary function. A recent retrospective report also describes the use of oral cyclophosphamides in a cohort of several cases of refractory myositis. So, I would like to further stress on the factor that cyclophosphamide is still reserved only for severe cases of myositis or systemic organ involvement, as such as interstitial lung disease, because of its side effects, including still long-term side effects of cyclophosphamide like malignancy, infertility risk are still not known. So, coming to another class of drugs called calcineurin inhibitors. There are mainly 2 drugs, cyclosporin A and tacrolimus. These are calcineurin inhibitors that exert their major therapeutic action by inhibiting T cell mediated immune response and suppressing the production of interleukin-2 and related cytokines. There is evidence for the positive effect of calcineurin inhibitors on muscular involvement in case series of 8 patients. 6 out of them were anti-Jo positive and 2 of them were anti-SRP positive. They showed a good response to tacrolimus. And it has also been used in the treatment of myositis-associated interstitial lung disease. So, presence of anti-synthetase antibodies seem to be related to a good response to calcineurin inhibitors. So, presence of antibodies helps us in identifying which drugs to be given in a given patient. So we can tailor the treatment for a given patient. So due to differences in molecular way of inhibiting and activity of calcineurin inhibitors, tacrolimus is supposed to be 100 times stronger than cyclosporine and has a longer half-life of more than cyclosporine. So this suggests tacrolimus has some advantages over cyclosporine for the treatment of myositis and associated interstitial lung disease. Even though both of them have the similar adverse events like hypertension, nephropathy, hepatotoxicity, and malignancy. So coming to tocilizumab, during COVID time, this injection has gained popularity. It is an interleukin-6 receptor antagonist and has been studied in a few case reports as a treatment for inflammatory myopathy. First report involving 2 patients with refractory Jo-1 positive polymyositis who showed a decrease in serum CK and resolution of inflammatory signs in muscle MRI imaging. In another report, a patient with an overlap syndrome involving dermatomyositis and systemic sclerosis refractory to multiple therapies showed improvement in clinical and laboratory parameters after treatment with tocilizumab. There is another mAb that is called cifalimumab. There is an increasing evidence suggests that role of interferon alpha and beta mediated immunity in the pathogenesis of myositis, and interferon induced genes and interferon regulatory cytokines shows overexpression in patients with dermatomyositis and polymyositis. So cifalimumab is an anti-interferon alpha monoclonal antibody, and its effect was investigated in phase 1b RCT in both polymyositis and dermatomyositis, and this treatment resulted in suppression of interferon signature in blood, muscle tissue, and patients with myositis. Subsequent trials are awaited. So what is the role of plasma exchange in myositis? Plasma exchange literature in myositis dates back to even 30 years back, where there was a retrospective study of 38 patients with plasma exchange between 1980 to 86, and 24 patients improved in functional status. A current paper from 2015 reported 3 cases of myositis with severe pharyngoesophageal involvement and muscle weakness, where plasma exchange was used successfully as a rescue therapy. So, plasma exchange is not a common therapy in myositis, but it may serve as a possible treatment in acute forms of myositis where the conventional therapy has failed or applied due to side effects. So, few slides on treatment of necrotizing myositis. As Dr. Raghu already mentioned, necrotizing myositis mainly due to anti-HMG-CoA antibodies or anti-SRP antibodies. The treatment of necrotizing myositis follows the same general therapeutic concepts as polymyositis and dermatomyositis. However, they show a poor response to this standard regimen and may require a treatment escalation or add-on therapy. A case series of 3 patients with statin-triggered autoimmune myopathy who could not receive corticosteroid because of diabetes showed a good clinical response to monotherapy with IVIG. So, several reports support the use of rituximab in necrotizing myositis, especially in SRP antibody positive. So, basically, we have to use either IVIG or rituximab. If both of them are not helpful, there is one case report which describes the successful use of CD34 plus autologous stem cell transplantation in patients with anti-SRP myositis. So, how should myositis patients with dysphagia be treated? Recommendation: IVIG is a recommended therapeutic option to treat steroid-resistant dysphagia with myositis. How should myositis patient with ILD be treated? Recommendation: administration of higher dose glucocorticoids in patients with acutely progressive and high-risk patients such as patients with immunosuppressions. How should myositis patients with cardiac involvement be treated? They should start with high-dose glucocorticoids along with 3 consecutive pulses of IV methylprednisolone. Should myositis and malignancy be treated simultaneously in patients with polymyositis and dermatomyositis associated malignancy? Recommendation is, unless symptoms of PM and dermatomyositis require urgent treatment, proceeding treatment with malignancy should be considered before starting treatment for inflammatory myopathy. So here's a chart which says first, initial and basic treatment with glucocorticoids. Second, immunosuppressive maintenance overlapping with steroids, either with methotrexate, azathioprine, or mycophenolate mofetil. And third line, we have IVIG, cyclosporine. At the last, in the therapy escalation, we have either rituximab or cyclophosphamide. It is a busy slide depicting the same what we have discussed now. Only new experimental therapies are there, like TNF-alpha inhibitors. There are many studies which says TNF-alpha inhibitors are not useful, may not be useful in patients with inflammatory myopathy. And JAK inhibitors, there are also newer drugs which have been tried in patients with inflammatory myopathy. So, to finish, initial response for glucocorticoids in inflammatory myopathy in the form of normalization of creatine kinase requires 2 to 4 weeks, 4 to 6 weeks, 6 to 8 weeks, 1 to 2 weeks. Next question. How should myositis with dysphagia be treated?
Answers, please.
Answers, please. So first question, answer is 4 to 6 weeks. Here, myositis with dysphagia be treated with IVIG. IVIG is the preferred choice. Can we have the preferred responses?
Yeah.
Okay, good. Next question. Presence of which muscle autoantibodies predict good response? Answer is anti-Jo1 and anti-MI2 both. Can you have the response? Okay, nice.
Right.
Okay. Thank you, sir.
Thank you, Dr. Mahendra. I think you covered extensively the various modalities of treatment that are available. And also, it was very important to recognize that finding out the different autoantibodies are going to make a big difference in selecting proper treatment modalities, because each one will be different in each autoantibody presence. So I think that was a very informative talk on management of idiopathic myopathies. And now the floor is open for question and answers. If there are any questions, please post them. There is one question, Dr. Mahendra.
No, sir.
Can you unshare your screen?
Cyclophosphamide for 6 months followed by azathioprine and methotrexate has shown benefit, relatively well tolerated. Your opinion, please.
Yes, sir. Cyclophosphamide is a well-known modality of treatment. As I said in my presentation, it should be used only in patients with severe muscle involvement with extramuscular involvement involving mainly interstitial lung disease or cardiac involvement. We can give pulse cyclophosphamides. Yes. Only in case of severe disease.
Other question is treatment of dysphagia while IVIG is not available.
So you can give us pulsed methylprednisolone, and continue other immunosuppressive medications and rise to feeding. You can also try plasma therapy. There are few case reports which says plasma therapy has been used as a modality of treatment in dysphagia. Preferred is IVIG, but you can also try plasma therapy.
The question is how about implicating steroid in a patient with heart failure due to cardiac involvement?
Sir, I did not get that.
How about implicating steroids in patients with heart failure due to cardiac involvement? Meaning,
steroids is anyway
use steroid in a patient who has got heart failure due to cardiac involvement?
Steroids is a basic modality of treatment. You have to continue the steroids. Maybe for water retention or increased preload, we may have to use additional diuretics.
I think the maximum dose of IVIG has been already answered by Dr. Mahendra. Somebody is asking about what is the maximum dosage of IVIG in a day.
So you 2 gram per kg divided over 5 days, but usually what we do is 0.4 gram per kg per day.
Correct. Right. I think that answers the questions. If there are no further questions, I thank all the speakers for their excellent work, and it was a very educative session on the idiopathic inflammatory myopathies, which is a rare condition, but we do come across off and on, and we will face a lot of diagnostic and therapeutic problem in this. So I think all the speakers gave their fullest effort to clarify all these doubts to our listeners. Thank you once again. As a chairperson, I would thank all the speakers for their excellent work, and I thank BNET for giving me the chance to chair the session.
Can I make a couple of points here, Dr. Sir?
Yes, sir. Go ahead. Go ahead.
Yeah, because I think it's a very interesting talk, and there are 2 or 3 points that I wanted to mention. Is one, the entity of polymyositis, I think, is overdiagnosed. I think 1 or 2 people have already mentioned about that. And there is a large study actually published several years ago where they had followed up for almost 20 years of review of all the histopathology, all the clinical features of almost 643 patients. And according to Peter and Bohan criteria, which is considered now obsolete, 76% of the patients who were diagnosed with polymyositis did not have it. And only 6% of the patients were meant to have polymyositis. Because at that time, when we were making a diagnosis of polymyositis and all that, we did not have all the special staining techniques for the muscle biopsies. Number 2, we also did not have autoantibody panels that we are having today. So with the autoantibodies available today and all that, it is important to question the diagnosis of polymyositis, especially in people who are presenting with proximal myopathy over the age of 45. If you make a diagnosis of polymyositis, most of the time you are likely to be wrong than right, because quite often their diagnosis will turn out to be either inclusion body myositis because they don't respond well to treatment, or they may have a necrotizing autoimmune myopathy, so-called NAM, or immune-mediated necrotizing myopathy. So it is important to actually test for the autoantibodies in suspected patients with polymyositis, because even if the biopsy findings are suggestive of endomysial inflammation, which we are looking for in compared to, for example, dermatomyositis patients who have perifascicular inflammation, perivascular inflammation, endomysial inflammation was considered as one of the classic features of polymyositis. Even that has been found in patients with inclusion body myositis. It is not specific for polymyositis at all. So autoantibody testing in patients with suspected polymyositis is important, number 1. Number 2, now inclusion body myositis is pretty, they say it's after the dermatomyositis, probably the second most common entity is inclusion body myositis. Anybody over the age of 45 presents with the proximal myopathy, even if the findings are symmetric. The textbook teaching is inclusion body myositis is asymmetric and all that. That's not always true. So inclusion body myositis must be in the top of your diagnosis, and you need to test for the autoimmune antibody panel. And the NT5C1A is one antibody, which Dr. Raghunandan mentioned about it. And it is supposed to be very sensitive. 60 to 70% of the patients may have that, even though it may lack specificity. But if you don't have other autoimmune disorders where that antibody can be positive, in, for example, patients with Sjogren syndrome, rheumatoid arthritis, they can have that antibody positive too. But if they don't have the clinical features to suggest any of those entities, and the patient has only myositis or proximal myopathy, testing that antibody may add additional clue to the diagnosis of inclusion body myositis. Number 3, you are always looking for congophilic vacuoles in inclusion body myositis, and quite often, in about 30% of the patients, you may not find that. So that's why further immunological testing or mitochondrial testing, mitochondrial stains, which are used for inclusion body myositis, is called Cox staining. And if the Cox staining negative fibers are there in a suspected patient with inflammatory myopathy, that is supposed to be highly suggestive of inclusion body myositis. It is important because quite a few of these patients are mislabeled as polymyositis, treated with a large doses of immunosuppressive therapy, because they think that they are not responding to the original immunosuppressive therapy, only to find out that later that these are the inclusion body myositis patients. So it makes a tremendous difference to the patient's quality of life and all that, because the inclusion body myositis, we don't have an effective treatment as present. Number 3, another point that I would like to make is about necrotizing autoimmune myopathy, or NAM. That's one short form used for that. Now, necrotizing myopathy is very commonly associated with SRP antibodies or HMG-CoA reductase antibodies. These two antibodies are very important to test in necrotizing myopathy patients. Now, you are always looking for statins in this patient. Are they taking statins and all that? When you take the history, quite often you don't find patient taking any statins at all. But I was told, I was really surprised about this. Some of the foods in Asian countries contain statins. Yes. And they say oyster mushroom. I don't know what that is because I'm not an oyster person, but oyster mushroom and some other food items contain statin, and you need to be aware of the food items causing necrotizing myopathy, because if they have SRP antibody positive, and they say rituximab is an excellent treatment choice for necrotizing myopathy for SRP positive antibody patients. There are some case reports and small case series suggesting excellent response to rituximab, whereas necrotizing myopathy associated with the HMG-CoA antibody responds very well to IVIG. So it is important. They are all treatable disorders. So misdiagnosing somebody as polymyositis when they have necrotizing myopathy or inclusion body myositis may harm the patient than do good. So that's the point I was wanting to make a mention. That's all. Thank you.
Thank you, Dr. Thank you very much again, BNET, for giving me the opportunity to chair the session. And I think everybody enjoyed all the talks, and we are looking forward for more such educative information from the BNET. Thank you very much.
Thank you, sir.
Thank you, Shrikant Swami, sir, for chairing the session. Thank you. I thank all the speakers.
Thank you.
Sir.
Thank you, Dada. Thank you for inviting me.
Thank you, sir. Thank you very much.
To meet you in person. Thank you. Thanks all the speakers and the participants. I thank Hallmark as well for organizing the nice program. So we look forward to meet you, all of you, again in 2 weeks.
Thank you.
Thank you all.
Thank you. Thank you all. Yeah.
Good night.
Good night. Good night.
All right. Good night, everybody.